Assalamu alaikum everyone, and today we'll be doing the Ptosis examination clinical skills. Things are a little different. I don't have my headphone. I'm trying out a newer configuration. I know it's towards the end of everything, but let's see how well this works. So let's define ptosis. Ptosis is an abnormally low upper lid eye margin position when the eye is in primary gaze, i.e. looking straight, and it can be either congenital or acquired. Most of the ptosis that you see is of the congenital variety, although it's not that you don't see acquired ptosis, you do certainly see acquired ptosis, especially in the cases of Bell's palsy and certain types of strokes and trauma. So let's just go over the upper lid elevators because those are the muscles that keep your upper lid at its normal place. And you basically have two, which is the levator palpebrae superioris, which is a skeletal muscle, a motor muscle, innervated by the third nerve. And this is your levator palpebrae superioris. It has insertions into the skin of the lid as well as the tarsal plate. So that crease that you see if you close your eyes real careful light, and you see in the mirror and you see this horizontal crease running across your eyelid, that is indicative of the fact that the levator fiber is properly developed and attached to the skin. If you don't see the crease, that's an indication that the ptosis is probably congenital in nature because the muscle never developed properly. The minor elevator is called the Muller's muscle. It lies underneath the levator palpebrae superioris. This is a smooth muscle which takes its innervation from the superior cervical ganglion, thus innervated by the sympathetic system. And it adds to about 2 millimeters of total elevation of the upper lid. Elevation means how much movement or excursion does the upper lid have. So let's just take a closer look at levator palpebrae superioris. This is levator palpebrae superioris, traveling from the orbit, passing through the orbital septum, attaching onto the skin, these fibers right here, seen by the upper dotted line, and also onto the tarsal plate. Tarsal plate is that organization of connective tissue within the lid that gives the lid its rigidity. It's really well developed in the upper lid as compared to the lower lid where it's sort of poorly developed. So it inserts into both, and this insertion is necessary because when you lift your lid, the skin is supposed to follow the lid. If it didn't, it would sort of bunch up here. So that's why you have fibers inserting into the skin as well. This is the levator passing through the orbital septum. So that's just a close-up view of the same thing. This is the levator palpebrae superioris. These are the fibers attaching to the skin, and these are the fibers attaching to the tarsal plate, so that both move in synchronously with the movement of the lid, the skin as well as the tarsal plate. So let's just see what this clinical skill entails, and it's one of the more interesting clinical skills. So you need a torch, you need a place where your patient can comfortably sit, and you need a scale. And these are the things that you are noticing when you're doing the ptosis examination. How much, if any, ptosis exists, what is or how good is the function of the levator muscle? Is there something called Bell's phenomena, which is basically when you forcefully close your lids, does the cornea or the eyeball rotate upwards as you forcefully close your lid? And this is a vestigial reflex. You know, like vestigial organs that don't really have any importance or we don't know their importance, like the appendix. This is a vestigial reflex. Another example of a vestigial reflex is your fingers or the tips of your fingers sort of curling up and you put them in water for a long time. Do any of you know why your fingers sort of curl up when they're in water for a long time? If you do, that's good for you. That's again a vestigial reflex, and that is when our ancestors, those who were hunting with spears, yeah, that far back. And when it was raining, they needed to have a good grip on things so that they can defend themselves or kill their foe. And that is why when it was raining, the fingers wrinkled so that when you were holding your spear or a rock, it was under a good grip because friction is reduced when you have a wet hand or the wet weapon that you have, stone or spears. So you develop wrinkles so that you don't lose the grip. We still have it, but we don't hunt with spears or stones anymore, mostly knives. And most of us don't even cut our own meat. I don't, so don't judge me. So this phenomena, Bell's phenomena, is again a vestigial reflex. So when you have something coming towards you at a very high speed, you want to close your eyes like so. And again, I'm talking about spears and rocks. And when you close your eyes really tight, the corneas are supposed to rotate upwards, i.e. the eyeball rotates upwards because it wants to protect the cornea. Remember, any trauma to the cornea uh, can potentially cause corneal scarring, i.e. loss of vision, whereas sclera is thicker and it's already opaque. So if something hits the sclera because something is really fast and approaching your eyes and it hits your sclera, chances are that A, it won't damage the really important vital structure, i.e. your cornea, if your eyeballs rotated upwards enough. And B, if sclera is superficially damaged, even if it heals by scarring, it's okay because it's not something that is essential to have as transparent, simply because it's not something that basically allows light to go through. So this phenomena basically guarantees that when you forcefully close your eyes, your corneas rotate up. And this is important for us, not because we are hunting or throwing spears or rocks at our patient, but this is something that tells us if post-operatively, remember when you're doing surgery for ptosis, you want the eye to open up normally. And what happens sometimes is, although your eyes open up normally after surgery, they don't close properly when you sleep because you did surgery. And it leaves a little bit of a slit. And if your corneas are exposed and you don't have Bell's phenomena, because Bell's phenomena is not something that you have equally good in every patient. Remember, it's a reflex that we are slowly losing because we don't use it, because nobody's throwing spears or stones at us. So if your corneas don't rotate enough, they will be exposed during the night and they will get really dry. So this is one indicator of how good the eye is able to protect itself in case that the eyes don't close properly when you sleep after surgery for ptosis. Then we have something called jaw winking, and jaw winking is one of the most interesting things. This happens that when your fifth nerve and your third nerve are sort of misdirected. It's the fifth nerve that's basically misdirected. Together with supplying your chewing muscles, the fifth nerve is also supplying your levator muscle. So what happens is when you start chewing, your levator contracts, relaxes, so you get that intermittent ptosis or a dancing upper lid as you chew. I'll show you a video and it'll sort of make it clear. It's mostly congenital, but can also happen post-traumatic, traumatic to the facial region. So when the fifth nerve tries to regenerate, some of the fibers sort of are misdirected towards the levator muscle. But more commonly, it's of the congenital variety where the misdirection is congenital nature. Finally, we have something called corneal sensations, and this is again something that's more important of a predictor of post-operative protection to the eye, and it is very similar to Bell's, i.e. when you are sleeping and your cornea is a little exposed because the eyes don't close properly after surgery, which is a possibility. Because you want the most of your eye opening, or the symmetry in eye opening, is when you're awake, so that everybody looks at you and your eye levels are normal. This corneal sensation tells you that although when you are sort of dozing off or sleeping and something goes inside your eye and strikes the cornea, you should be aware of it, so you wake up and clean your eyes. If your corneal sensations are poor, for example, you have had diabetes or keratitis because of herpes zoster, I'm sure you've done that by now, and your corneal sensations are poor, if something goes in your eye, and there are other diseases which cause poor corneal sensations. But anyways, sorry. If your corneal sensations are poor and your eyes are a little bit open and your Bell's phenomena is not that good and something goes and strikes your cornea, it'll be there for a very long time and cause a little bit of inflammatory reaction and dryness, and can further accentuate problems, especially if you have a negative Bell's. Actually, it is usually seen in negative Bell's or Bell's that are not very good, so that a little bit of your cornea is exposed. And when you sort of have poor corneal sensations together with negative Bell's or really poor Bell's, and your cornea is exposed, A, you're sleeping, so your sensations are numbed anyways, and B, your corneal sensations are so poor, even if something goes in your eyes at night, you won't even know it. And when you get up in the morning, your eyes are red and inflamed because you don't know something went inside your eye. So corneal sensations and Bell's phenomena are something that are indicators of post-operative protection to the eye. And there are things that if these things happen, if you have poor Bell's or negative Bell's or poor corneal sensation, it doesn't mean that you don't do surgery. You just take precautions, tell the patient to wear glasses or patch the eye before sleeping. So there are ways, but you should know this beforehand before you, so you're able to tell your patients what to expect after surgery. So we are now going to start the examination, and we are going to start by measuring the amount of Ptosis. And you might have read something called marginal reflex distance written in brackets. To measure Ptosis, the first thing that we need to do is to determine the position of the upper lid. So that's to figure out, does the patient have any Ptosis to begin with. And marginal reflex distance is the distance between the light reflex of the torch that's illuminating the eye and the highest point on the upper lid. This is the highest point on the upper lid. This is the reflex of the torch that's illuminating the eye. And the illuminator has to be at level with the eye, not going like horizontally oblique or even oblique in any direction. It has to be dead on with the eye. If this is the eye, this has to be the torch. The torch can't go like this. Oh, I have a real torch. It has to be like this, dead straight. It can't be like this. It can't be like this, because then the light reflex sort of is not in its proper position. So the distance between this light reflex, which should be centered on the pupil or the cornea, pupil is easier because it's a smaller target and it's easier centering on the pupil. So this light reflex, which is centered on the pupil, and the highest point on the upper lid, the distance between these 2 points is called a marginal reflex distance. At an undergraduate level, we don't ask you or expect you to take a scale and measure this marginal reflex distance. The scale comes in later. We expect you to take a mental note of this distance. So when you're examining normal patients, you can do that at home because I'm sure everybody around you is normal. This distance is about 4 millimeters. And why is it 4? Well, let's look at this eye, and this eye is sort of different from a normal eye, because normally, as you can see here, the upper 2 millimeters of the cornea are covered by the upper lid. So that's the normal resting position of the upper lid. The upper lid covers the upper 2 millimeters of the cornea. This is a person who is forcefully opening his eyes to show you all of the cornea. And the reason this is done is to show you that the corneal diameter is 12 millimeters. And the radius is 6 millimeters. And the upper 2 millimeters are covered by the lid. So the visible distance between the highest point on the upper lid and the center of the cornea, which is denoted by the centering of our light reflex in the pupil, is thus 4 millimeters. 6 minus 2, which is 4 millimeters. This is the marginal reflex distance. So you need this value in order to calculate how much Ptosis a patient has. So let's look at this picture. This is the right eye, this is the left eye, and we are going to measure the amount of Ptosis based on our marginal reflex distance that we measure. And the amount of Ptosis is 4 minus observed marginal reflex distance, because remember, the normal distance between the light reflex centered on the pupil to the highest point on the upper lid is 4 millimeters. So if our observed marginal reflex distance is 4, the amount of Ptosis is 0. And yes, this is 4. I know it doesn't look like 4, but believe me, this is sort of not to scale. This is 4. This is 3. So the amount of Ptosis in the left eye is 1 millimeter. The color of the irises is different, so is the pupillary size. We'll do that once we talk about Ptosis in a video discussion. So this is all nice when you can actually see the pupillary reflex. I mean the corneal reflex, the reflection of the torch. But what, not the pupillary reflex, that was around, but the reflex of the torch light, or the light of your illuminator, you can measure the marginal reflex distance. But what about this person here shown in the inferior picture, or the picture below this one, where you can't see the reflection from the illuminator? That's because the lid is too low. Then we'll have to modify our formula for marginal reflex distance, because marginal reflex distance depends upon a visible reflection of light, and we can't see it now. So we modify our formula. And the formula modified is that we measure the distance from the lowest point on the inferior limbus to the upper lid in a straight line. And whatever this distance is, we minus 6 from it. 6 is the radius of the cornea. So now what we are trying to do, rather than take the reference from the light reflex that we saw, we are taking reference from the inferior limbus. So we draw a straight line from the inferior limbus all the way to the position of the upper lid, and we measure this distance, and we subtract 6 from it. This is our MRD in cases, marginal reflex distance, in cases where the lid is so low you can't see the reflection of your illuminator. And our amount of ptosis then becomes 10 plus the observed marginal reflex distance. Remember, the maximum distance that this can be is 6, because the pupil, this corneal reflection is supposed to be at the center. If you go back to this picture rather quickly, sorry, rather, here we go. So this is where a reflection of the illuminator is supposed to be, right at the center. And we are measuring distances below it because our lid has covered this. So the best position, or the position could be that the lid is just covering the pupillary reflex. So the distance between the inferior limbus and the highest point in the upper lid is going to be 6 millimeters. But if the lid is any lower, this distance is going to be less than 6. And because we are subtracting the distance from the lowest point on the limbus to the upper lid, this number is going to be either 0, because remember the maximum distance is going to be 6 if the lid is just covering the pupillary reflex, or in most cases less than 6, because the lid is going to be lower than the pupillary reflex. So we measure this distance. Let's assume that this distance right now is 4 millimeters. So our modified marginal reflex distance is 4 minus 6, which equals minus 2. And this is minus. It is telling you that your lid is now below the center or below your light reflex. So the distance now, the marginal reflex distance is negative because the lid is covering the reflex. I hope you understand that. It's not that difficult. Just go over it again if you can. So the amount of ptosis is 10 plus the observed marginal reflex distance. 10 because that's the visible diameter of your cornea, because remember the upper 2 millimeters are covered by the lid normally. So in this case, 10 plus minus 2 is 8 millimeters, so our ptosis is 8. And that also makes sense. See, the entire corneal diameter is 12, right? And we have measured that our lid is 2 millimeters below the center of the cornea, or the center, or the reflection of the torch. So if it is 2 millimeters below, it is 2 millimeters below the center of the cornea, and the radius of the cornea, i.e. from the periphery to the center, is 6 because the diameter is 12, 6 plus 2 is 8. So you can measure it that way, but the easier way is simply add 10 to whatever marginal reflex distance you observed, and that gives you your amount of ptosis. So this dotted line is representing the diameter of the cornea, and of the total diameter of the cornea, the lid is covering 8 millimeters, leaving about 4 millimeters gap inferiorly. I know it looks more than 4, but because this picture is again not drawn to scale, unfortunately, but when we measured it and it was actually done, it is actually 4. So when the pupillary, the light reflex of your illuminator is visible, it is very simple to calculate marginal reflex distance. You just take that, mentally take it up to the highest point on the upper lid and say, yeah, this distance is about this much. And then you minus 4 from your observed marginal reflex distance, and that gets you your amount of ptosis. The issue is actually when the lid is so low that it covers this, the reflection of your illuminator, then the marginal reflex distance becomes a little more complicated, because first we need to modify a formula for MRD, marginal reflex distance, since we can't see the reflex anymore. So we take the new benchmark, or the point of reference, as the inferior limbus, the 6 o'clock position, and we measure up from it. And whatever value we get, we subtract that from 6. And the maximum value can only be 6, because remember, this light reflex is the center, and the center is 6 millimeters from the top and 6 millimeters from the bottom, because the corneal diameter is 12. So if it is just at the light reflex, this distance would measure out to be 6. And then marginal reflex distance would be 6 minus 6, or 0. That your lid is at the position of the reflex. If this distance is measured to be less than 6, that means your lid is now below the level of the reflection of the illuminator that you see here. In this case, like in this case, it's 4, so that means the lid is 2 millimeters below the position of the reflex. So all you then do is you subtract 10, or you add 10. The value would either be 0 or in minus, to whatever marginal reflex distance you got, and you get your amount of ptosis. We don't do 12 because remember the upper lid is already covering the upper 2 millimeters. So we measure this as, we take this as 10 because that's the normal area of the cornea that's visible to you. The upper 2 millimeters are covered by the lid normally. So this is how you calculate the amount of ptosis in a case where you can see the light reflex, and also in a case where you can't see the light reflex. Reflection is the proper word. So let's measure amount of ptosis here in right and left eyes, and obviously it's 0, but let's see if you can do it. We take this point and we measure upwards. We take this point and we measure upwards. So here it's easy because the highest point of the upper lid is corresponding to the this light reflex, but here the highest point is sort of here. So how do we measure this? This is a straight line, so we don't measure obliquely. We go horizontally first, and then we measure. So here you have a little bit mathematical calculations going on in your head, because undergraduates are not expected to put a scale in front of it and measure. If you do that, there is nothing wrong with it. But undergraduates can just make a mental calculation of the marginal reflex distance. You don't need to be very accurate and use a scale. So this is amount of ptosis. Then we measure levator function, which is very easy. Levator function means we need to see how good the levator is functioning. And one thing that interferes with levator function is the function of your frontalis muscle, because the frontalis muscle, if you apply enough contractile force, can also lift your lid. So the thing you do is you use a horizontal thumb. Obviously, you're telling your patient, taking the consent and telling you're going to touch him or her, and you use a horizontal thumb and you place it gently but firmly on the brow so that the frontalis cannot help lift the lid. You ask the patient to look as far down as possible while keeping the head straight, because it's easier for you to measure. Take your scale and align any number with the lowest point on the upper lid. So for example, here it's 2. And then you ask the patient to look up as possible. So ऊपर देखें, जितना ऊपर देख सकते हैं. And then you align, and whatever number is coming here, making sure that your scale doesn't move from where it was first. And remember, your lower lid also moves upwards a little bit. So my scale hasn't moved. It's where it was. The positions of the lids have moved, but we are only interested in the upper lid. So the upper lid moved from 2 millimeter mark, or 2 centimeter mark, sorry, or 20 millimeter mark, all the way up to, let's call it 4 millimeter mark. So how much has the lid moved? Well, it has moved 20 minus 4, or 16 millimeters. And if you go back, 16 is excellent levator function. Then we have the two other things, corneal sensations and Bell phenomena. We have already described that they are basically a measure of how the eye will behave after surgery. And it's important because sometimes after surgery, the eyes do not close completely. And that is really important when you're sleeping, because if you have poor corneal sensations, the patient will not be able to sense something going in your eye. And if the Bell's phenomena is negative or poor, that would mean that your cornea would be exposed, it would dry off. And if the corneal sensations over that are negative, the patient won't even feel anything touching the cornea. If your Bell's phenomena is good, that's very nice, because that means your cornea would have some protection. But sometimes the Bell's phenomena is in between. So a little bit of your cornea might be visible. So in that case, again, corneal sensations have to be good if the patient needs to know that something is in his eye. And remember, when you're sleeping, your sensations are numbed anyways. So corneal sensations, again, together with Bell's phenomena, indicate how the eye would behave post-operatively in situations where it doesn't close properly when you're sleeping. And that is something that you see. It's not something that you rarely see. It is something that is seen. So this is how you do corneal sensation. You ask the patient to look away so that the blinking is not because of something approaching the eye. And then you touch the cornea, making sure you don't touch the lashes, because you touch the lashes and you generate the reflex from the lashes. You touch the cornea, and the patient should close his eyes if the corneal sensation is to be positive. And this is Bell's phenomena. Look, the patient has closed his eyes, and I am asking her to not let me open my eyes. Let her open her eyes, and I'm pulling the upper lids upwards. And I don't see the cornea because the eyeballs have rotated upwards. And I just see the sclera. So this is very good positive Bell's phenomena. Finally, jaw winking. I'll show you 2 videos. So this is very easy for you to know. No jaw winking. And then we will also see this patient here. This is what jaw winking. If you want to see the complete video with a lot of audio in it, you can go to the videos folder. The entire video, 13 seconds long, is there, introduces the patient appropriate. But this is what jaw winking. So finally, we are now recording our findings, and we say amount of ptosis, which is based on marginal reflex distance. In our case, it was no ptosis. You'll see that when we do the video, the levator function is about 15 or 16 millimeters in both eyes. Whatever levator functions you see, Bell's phenomena is positive, corneal sensation is positive, jaw winking negative. Any of these things that change, you just change these values here to you record any abnormal values that you find. So thank you very much. We are going to go over to the video. One thing that you need to understand again is when you're doing this assessment of ptosis, if you see any swellings, you stop the test. You ask the patient, do these swellings hurt? And then take permission from your examiner or faculty member. Can I do this test in spite of the fact that there is this swelling and it might actually hurt the patient? So let's go see the method. And thank you very much.
अस्सलाम वालेकुम।
वालेकुम अस्सलाम।
मेरा नाम डॉक्टर अली है। आज मैं एक रूलर और टॉर्च की वजह से आपकी आंखों का मुआयना करूंगा। मुआयने के दौरान आपको कोई दर्द या तकलीफ नहीं होगी। क्या आपकी इजाजत है? ठीक है। आपकी आंख में मैं थोड़ी सी टॉर्च से रोशनी डालूंगा। आप सीधा टॉर्च की रोशनी में देखती हैं।
ठीक है।
सीधा टॉर्च की रोशनी में देखें। The first thing that we do in ptosis examination is basically to calculate the marginal reflex distance, which is the distance between the highest point on the upper lid measured from the center of the pupil, which is identified by the reflection of the torch's illuminator falling onto the cornea. And from that we can calculate the amount of ptosis, which will follow up when we are recording our findings. Now we are going to measure the levator function, and for that we need a scale. मैं थोड़ा सा आपको हाथ लगाऊंगा, ठीक है? आप सामने सीधा देखती रहे। माथे की तरफ आपको मैं हाथ लगाऊंगा और आपके सामने ये रूलर लेके आऊंगा। Use your thumb and firmly but gently press onto the brow of the eye that you are testing, making sure that you don't stand in front of the patient, so you use your appropriate hand. For the patient's right eye, use your left hand. With the other hand, bring a scale. नीचे पैरों को देखिएगा and align any number on the scale with the lowest point on the upper lid. ऊपर छत को देखिएगा and measure the excursion of the upper lid by noting the number next to the position of the upper lid when the patient is looking up. दोबारा नीचे पैरों को देखें. May readjust your hand if you want to do it another time. दोबारा ऊपर छत को देखिएगा. And this helps us measure the levator function. We'll note these findings at the end. सामने सीधा देखते रहिएगा. अब मैं आपको एक टिश्यू पेपर की थोड़ी सी नोक बना के आपकी आंख के करीब लूँगा, ठीक है? इसमें आपको थोड़ा सा महसूस होगा टिश्यू पेपर लगता हुआ, दर्द या तकलीफ आपको नहीं होगी। आप मेरी उंगली की तरफ देखें। मेक श्योर दैट द पेशेंट इज पॉइंटिंग अवे, सो द ब्लिंक इज नॉट बिकॉज ऑफ द ऑब्जेक्ट अप्रोचिंग द आई, एंड वी वांट टू चेक द कॉर्नियल सेंसेशंस। मेरी उंगली की तरफ देखती रहें। Check very gently, touch on the cornea, making sure you don't touch on the lashes. So I'll show you once more. मेरी उंगली की तरफ देखें. Don't touch the lashes, touch the cornea. ठीक है. Now we are going to check markers and jaw winking. आप चबाएं जैसे बिस्किट या च्युइंग गम चबाती हैं, and see if this is associated with any lid movement. And finally we are going to see the ठीक है, शुक्रिया. We are finally going to see the Bell's phenomena if it's positive or not. मैं दोबारा से आपकी आंखों को हाथ लगाऊंगा. आपने अपनी आंखें बंद कर लेनी है. मैं आपकी आंखें खोलने की कोशिश करूंगा. आपने मुझे खोलने नहीं देनी, ठीक है? आंखें बंद कर लें. Use thumbs of your both hands and again approach from the side as much as possible. And आंखें बंद करें. Gently pull the upper lids up. And see if you see the sclera or the cornea. If the Bell's phenomena is positive, you should see the sclera, the cornea, or the eyeballs being rotated up. आपका बहुत बहुत शुक्रिया.